Hi everyone, so this is your Flight Physiology, Stressors of Flight, and CAMPS lecture for critical care. So let's get started. First thing we want to go over is the atmosphere. So you can see here, the atmosphere is made up of 21% oxygen, 78% nitrogen, and 1% floating other stuff. Argon, CO2, neon, helium, blah, 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 all that stuff. This is in the air that we breathe every single day. We want to make sure that we know oxygen is 21%, nitrogen is 78%, and again, 1% other, no matter where we are. Whether we're at sea level, 1,000 feet, 7,000 feet, wherever we are, it is always 21% and 78%. What we do need to remember, though, is with an increase in altitude, there is a decrease in pressure. So going over that, oxygen transport in the blood is, of course, dependent on the partial pressure of oxygen. If there's more oxygen outside than there is in your bloodstream, O2 is going to move from your lungs to your blood. If there's more in your blood than in your lungs, it'll go out the other way. Just a little visual, moving from high concentration to low concentration, and then just kind of bouncing back and forth until we get pretty equal. Okay, physical zones of the atmosphere. The first one is the efficient zone. This is where helicopters are going to be flying. The next one is your deficient zone. This is 10,000 feet to 50,000 feet. This is where our fixed wings will fly. And then you have your space equivalent zone.
Captain's log, stardate 2126.3. First Officer Spock reporting. Still no word from Captain Kirk on the surface below us. Waiting time is almost up. I will soon be forced to attempt departure as per instructions.
Anyways, your space equivalent zone is 50,000 feet and above. Know that we need to have oxygen on board anytime we're 10,000 feet or above. That does not mean that we actually have to have the oxygen on. It just means that we have to have it available. Principles of atmospheric pressure. So, a 1 square inch column extending from sea level to the edge of space is 1 atmosphere. 1 atmosphere weighs 14.7 pounds or 760 torr. And torr is millimeters of mercury. Just the same measurement, just a different name for it. So what we need to notice from this diagram here is seeing that it is more dense the closer we get to sea level. There is more pressure the closer we get to sea level. And by the time that we get about halfway to space, about 18,000 feet, the pressure is only 380 torr. So the higher up you go, the less pressure you have. So let's go back to this one here. Say that little white dot over in the left-hand corner is a fixed-wing airplane. Now, what do we think is going to affect our patient more? So, do we think it's going towards from high level to low level, or from low level to high level? Okay, so let's think about this. In a fixed wing, the pilot will actually start to change the pressure inside the cabin to match the barometric pressure of where you're going to land. So if we are going from a high altitude to a low altitude, our barometric pressure will actually be higher when we land. So we will have more available oxygen. The partial pressure of oxygen will be higher. That's good for our patient. However, if we are going from a low altitude to a high altitude, the barometric pressure is less, therefore the partial pressure of oxygen is less. Therefore, the worst thing for our patient would be taking our patient from a low altitude to a high altitude. So let's look at this here. You see our 1 inch column of air, our 1 atmosphere. But let's look at divers. So every 33 feet that someone dives, it is called diving an atmosphere. So 33 feet, 66 feet, and 99 feet. If our diver went to 66 feet, he has 3 atmospheres on top of him because we have to count the atmosphere that is sitting right above him. However, if you want to know how many atmospheres of water the patient has above them, they only have 2 atmospheres of water. So 3 atmospheres, 2 atmospheres of water. So let's get into our gas laws. And these are all these great men who teach us something. So the first one is Boyle's law. The volume of gas is inversely proportional to its pressure or temperature remaining constant. Okay, so the way we're going to remember that is by Boyle's balloon. So you have a balloon, let's look at our bottom one, and you let this balloon go up into the atmosphere. Because the pressure is less once we're getting up there, that it has the ability to expand. So we go up in atmosphere, it expands. But we bring that balloon back down, the pressure is more, the balloon will shrink. Boyle's law, Boyle's balloon. So let's go over some things that this would actually affect. So the first one, pneumothorax. We will never, should never, take any patient that has a suspected pneumothorax into a helicopter, taken into altitude, without some type of corrective action being done, whether it be a chest tube, a chest dart. If we take this patient up into atmosphere, that pneumothorax is going to get worse, expanding that air pressure. All right, so pneumocephalus. This is air within the brain, within that skull cavity. When we take these patients up into atmosphere, that air is going to expand, causing higher ICP and possibly herniation, really bad things. So, if you can, any patient that has a head injury or suspected pneumocephalus should be taken by ground. So, ostomies in our gastric tubes. Our main goal there is do not trap air in these. On your over here on your NG-OG tubes, don't clamp them off. Our esophagus has a really good way of closing off. It doesn't let any air in. However, if you have an NG or OG tube in, you take them up into atmosphere with this thing clamped, all that air that's in the stomach is going to expand, and it's coming out one way or another. And I would rather just vent that OG tube to atmospheric pressure. So kind of let it equalize itself. On your atriums for your chest tubes, you'll know that blood comes in here, will fill up this chamber, and then this chamber, and then this chamber. But there's air still trapped in here. So we will actually start pushing the blood back into the patient. That's obviously not good. There are 2 things that we need to do. One, make sure that our collection chamber is vented to atmospheric pressure, and most nowadays are. We also want to put a flutter valve on there. Air can only go out and it cannot get back in. Also remember your Foley bags. The inside, the actual part that's in the bladder, is not that big of a deal because it's filled with water. But here in the bag, this part actually has air in it. So when we take them up into atmosphere, all that dirty urine is going to start going back up that tube and back up into your patient. Not a good thing. With your ET tubes, there is air in that cuff, so that will expand. For us doing fixed wing, not really that big of a deal. It's not going to happen that often. For long transfers or something you're going to be flying at high altitudes for, you may want to consider just checking the patient's cuff, so squeezing on the pilot bulb to make sure it's not too tight, and you may have to let some air out of it. If you were on a fixed wing, you may want to consider replacing that air with water. Same thing with air splints. Make sure that, or mask pants if you ever see those, As we go up into atmosphere, these are going to expand, causing it to essentially crush that ligament. So make sure you're checking these. Make sure you're checking pedal pulses. Let's go into our dysbarisms. So the first one is barosinusitis. So we have sinuses here, here, here. This is where you get air trapped in those sinuses, so you have a cold, you're just stuffy, you don't feel good. When we go up into atmosphere with these, that pressure expands. You can actually rupture your sinuses because of this. Not good, sounds extremely painful. What we can do is the Afrin, the nose spray, just try and clear some of that up. But the best thing to do is if you're sick, don't fly. We need to know that this is an ascent problem. So this is when we're going up into atmosphere that this barosinusitis will happen. So now a really fun one, barotitis media. So just for its and grins, let's say that that is the eardrum. I'm very well aware that the eardrum is back behind there, but for illustrative purposes. So that's our eardrum. When we ascend, the pressure on the outside of that eardrum becomes less. So this will cause our eardrum to go outward because the pressure in the middle ear is higher. Now it is very easy for us to push some of that air out our eustachian tube by just doing the Valsalva maneuver, which will cause our ear to do this again. However, when we're in descent, now we're all normal, but the pressure is now more on the outside of our ear. We cannot easily clear that eustachian tube to bring air back in, whether it be from clogged eustachian tube, dirt, grime, nastiness, whatever it may be, or you just have a cold. It's very difficult to get air back into that middle ear. That's going to cause our eardrum to push like this, and eventually it's going to rupture. So our barotitis media is a descent problem. Ascent we can clear just fine. Descent is when we're having our issues. And barobariotrauma. So barobariotrauma is for your patients that have excess adipose tissue. And in that excess adipose tissue, you have nitrogen trapped in there. When we go up into atmosphere, that nitrogen expands and will go into our bloodstream, essentially causing the bends. What we can do for these patients is we need to pre-oxygenate them with 100% FiO2 at least 10 minutes prior to takeoff. This way we're changing the partial pressure of oxygen in our lungs. We can blow off more of that nitrogen as we ascend. So that essentially wraps up Boyle's law. So let's go into Charles' law. Charles' law says that at a constant pressure, the volume of a gas is directly proportional to the absolute temperature of that gas. So this is very important. At a constant pressure, the volume is directly proportional to the temperature. So Charles centigrade, constant pressure, volume of a gas to the absolute temperature. So volume, volume, volume. With that being said, if the temperature goes up, the volume will expand. If the temperature goes down, the volume will shrink. Volume. I know I keep saying that, but it's important to remember. So we need to consider our patient's thermoregulatory status. If they're already in shock, we need to make sure we give them warm blankets, maybe some warmed IV fluids. They cannot regulate their own body temperature. We're going to have issues. So moving on to Gay-Lussac's law. This law says that at a constant volume, the pressure of a gas is directly proportional to the absolute temperature of that gas. The pressure. This one is taking Charles Law and putting it into a fixed container, like our O2 tanks. So you leave your O2 tank out on your stretcher during the day, and the pressure reading, I'm just going to make something up, is 1,000 psi, right? So our pressure goes up when the when our pressure goes up when the temperature goes up. You go back and check it that night when it's nice and cool, your pressure is going to be lower. The temperature went down, the pressure went down. Gay-Lussac is with pressure. Consider your oxygen cylinders. We just went over that. Henry's Law, this is one of my favorites. The amount of gas over a solution is directly proportional to the amount of gas dissolved in that solution. So we've all seen a long neck beer bottle. So as you can tell in here, there is this much air between the liquid and the cap. That right there is CO2. So the same exact amount of CO2 that's over this is within the beer. That is why whenever we pop that top on there, that cap, you get that psh sound, and all the bubbles start rushing up to the top. That's because it's releasing some of that CO2 that was in that beer. So what does this have to do with? Decompression sickness is our big one. If there is more oxygen outside, or if we're equal within our bloodstream and our lungs, everything's going to be just fine. You know, there's the same amount on top that there is on bottom. However, if you have an explosive decompression, all that oxygen on the top is removed, so all the oxygen in your lungs, and everything from your blood is going to start going back into your lungs, and you're going to start breathing out oxygen. So what do we need to do for our decompression sickness? We need to descend immediately. We need to put 100% FiO2 on and land at the nearest place where qualified medical assistance is available. And the qualified medical assistance we're looking for is hyperbarics chamber. Evolved gas disorders are considered serious medical emergencies and require emergent specialized care. This can include diving or a decompression from an airplane, as you can tell by my seahorse over here. So there are different types of decompression sicknesses. The first one is the bends. This is where nitrogen bubbles become trapped in the joints. Onset is mild, eventually painful. Then you have the chokes. These are where the bubbles block those smaller pulmonary vessels. They'll have a burning sensation. They'll be wanting to cough. And eventually, they'll have a sense of suffocation. You've also got the creeps. This is where the nitrogen bubbles form along those nerve tracts. Burning, tingling, itching, maybe even a red rash. The staggers is where nitrogen bubbles affect the spinal cord. They produce visual disturbances, paralysis, and one-sided tingling. So our next law is Dalton's law. This is the pressure exerted by a mixture of gases is equal to the sum of the partial pressures of each gas in the mixture. You can remember this one of two ways, either Dalton's gang or Dalton's a dunce, because he didn't know that 1 + 1 = 2. So basically what this is telling us is we know that oxygen is 21%, nitrogen is 78%, and there's 1% other stuff. So if we know our total barometric pressure, we can take this, we can figure out the oxygen and we can figure out the nitrogen by taking 21% of the barometric pressure. Why is this important to us? So the oxygen correction formula, this is basically telling us the FiO2 that our patient needs to be on when we reach our altitude. So what we can do is if your patient is on a very, very strict FiO2, they need to be at 35%. What we can do is take the beginning barometric pressure, so where we're at, multiply that times their FiO2, and then divide it by our maximum altitude barometric pressure. So whether you're going into a higher altitude or a lower altitude, this will still work. So basically, I am looking at, 35%. Okay, so 35%, and we're starting off at sea level, so multiply that times 760. And then we're going to 10,000 feet, and your pilot should be able to tell you that the barometric pressure there is 523. So we multiply 35 times 760 divided by 523. When we get to 10,000 feet, our patient needs to be on an FiO2 of 51. And our last gas law is Graham's law. The rate of diffusion of a gas through a liquid membrane is directly proportional to the solubility of the gas and is inversely proportional to the square root of its density or gram molecular weight. Got that? Cool. Basically, this is just saying how easily a molecule will move across a membrane. Again, why is this important to us? Well, CO2 has a solubility factor 20 times greater than O2. With that being said, if your patient has CHF and they have fluid in their lungs, CO2 is going to move through that membrane a whole lot easier than oxygen will. So we want big, dry alveoli in order for that oxygen to move across that membrane. We are done with gas laws. Yay! So let's move on to stressors of flight. One of the main stressors of flight is hypoxia. And there are 4 different types of hypoxia. Hypoxic hypoxia, hypemic hypoxia, histotoxic hypoxia, and stagnant hypoxia. We're going to go over each of these. So the first one here is hypoxic hypoxia. This is what most paramedics think of when we think of hypoxia. So basically, this is just somebody has a plastic bag over your head and there is not enough oxygen available. So this is reduced partial pressure of oxygen in the lungs. So the blood cells will have some hemoglobin on them. The body tissue can receive that. There's nothing wrong with the red blood cells. There's nothing wrong with the body tissue, but there is not enough oxygen in the lungs. Hypoxic hypoxia. We need to know that this is also called altitude hypoxia. So hypemic, this is the inability of the blood to accept oxygen in adequate amounts. So this is a problem with the red blood cells. This can be from COPD, pneumonia, pulmonary edema, pulmonary embolism. Those oxygen molecules cannot cross that membrane, therefore they cannot attach, or the blood cannot accept that oxygen. One of our biggest contributors here is carbon monoxide. Histotoxic, this is the inability of the cell to accept or use oxygen. So our red blood cells or the body tissue is having an issue. So cyanide, anaphylaxis, alcohol, overdose, the cell cannot accept or use that oxygen. Biggest contributor here, alcohol. And then you have your stagnant. This is blood is not moving. So reduced blood flow from myocardial infarction, a cardiomyopathy, cardiogenic shock, or even you can have localized hypoxia from a crush injury. If that blood is not moving, it can't deliver the oxygen to that body tissue. Stagnant hypoxia. Big one here for us are G-forces. So let's talk about the stages of hypoxia. First, you have your indifferent stage, your compensatory stage, your disturbance stage, and then your critical stage. So in your indifferent stage, this is you are between sea level and 10,000 feet, Basically, the only thing that's going to happen here is you're going to have a decrease in night vision at about 4,000 feet. By the way, smokers are in a constant state of indifferent. They're in that stage of hypoxia. So then we move into our compensatory stage, and this is 10,000 feet to 15,000 feet without oxygen. So you have impaired efficiency, a decrease in motor skills, drowsiness, and poor judgment. Then you go into your disturbance stage. This is a complete loss of those motor skills, a complete loss of judgment, complete loss of cognitive function. You're just kind of there. This is between 15,000 and 20,000 feet without oxygen. And then, of course, as your disturbance stage, we've got coma, convulsions, and death. This is 20,000 feet and above with no oxygen. Time of useful consciousness. This is the time that you go from an oxygen-rich environment to an oxygen-poor environment. And this is usually pretty quickly is when we're talking about time of useful consciousness. This would be like an explosive decompression in a fixed wing. We want to protect ourselves first. But protecting ourselves, we need oxygen on pretty quickly. It will be your time of useful consciousness. If you ever get asked this on a test question, it's usually the lowest number there. So you have an explosive decompression at 18,000 feet. I would choose the lowest answer there because there's no way to really predict what each person's time of useful consciousness will be. It's kind of dependent on the person. If they work out, if they smoke, if they eat right. Any of that, it's each individual person type thing. So just choose the lowest number. Protect yourself first. So the self-imposed stresses. We use the death mnemonic. So drugs, and not just illicit drugs, but Benadryl, anything that could make you sleepy. So even over-the-counter drugs. Exhaustion. Us in EMS, we like to work 4, 5 jobs, and we're always tired. Be sure to get a good night's sleep before you go out and fly. Alcohol. Don't drink before shift. And remember, some of the medications that we take have alcohol in them, such as Dayquil or NyQuil. So just be careful with your drinking. Tobacco. While dipping is bad, smoking is worse. Remember, at that stage, we're always in the indifferent stage. And then hypoglycemia. Not hyperglycemia, but hypoglycemia. The vibrations within that aircraft will cause our metabolic system to speed up. Therefore, we're burning a lot more of our fuel, and we become hypoglycemic very easily. Be prepared to deal with these factors in your patients also, not just you, and your patients. So, gravitational forces. How will you load your patient? So, in a helicopter, it's really not that big of a deal. We're not doing straight takeoffs. But in a fixed wing, it's kind of important. So let's say that you have a patient who is in labor and the baby is breech and you're in a fixed wing. And we're trying to stop labor to get her to a bigger facility. So how would you load this patient? Would you load them with the feet towards the pilot or the feet away from the pilot? Well, I would want to load them with the feet towards the pilot because then when we're going to take off, those G-forces aren't causing an explosive delivery. Now, when we talk about a patient with ICP, we would want to load them with the feet away from the pilot. Once again, when we take off, we would want the head, all the blood, to go towards the feet and not be pooling even more in our head. Noise, you should have headphones on, some type of hearing protection, especially in a helicopter. They're loud. You're sitting right underneath the engine. You can't hear anything. You should also have earphones or at least those little foam things for each person that is going to come near your helicopter. Vibration can override the normal thermoregulatory mechanism. Like we said earlier, it'll increase your metabolism, so we become hypoglycemic, but it also burns off all that fuel, and we're going to get cold pretty fast. So make sure you protect not only yourself, but your patients from that. Okay, guys, last little bit, I promise. We're going to go over CAMPS, which is the Commission on Accreditation of Medical Transport Systems. Currently, CAMPS has come out with their 10th edition, but the FPC is still working off the 9th edition. So that's the one we're going to go over. So CAMPS, like I said, Commission on Accreditation of Medical Transport Systems, they have no requirements. And what I mean by that is they make recommendations to medical transport systems. And you must meet a minimum amount of these recommendations. I'm just going to throw a number out there. I don't know if it's right or not, but 70%. So if you meet 70% of their recommendations, you can be CAMPS accredited. The Army is not CAMPS certified. So some things that CAMPS states is continuing education. So you have to have an initial training program, a didactic component, and clinical competencies specific to your transport system. So if you only do NICU transports, you don't need to go do extrication classes. But if you're like AirLife and you do everything, you must keep up with all of your didactics. On the clinical competencies, airway is a huge one. So you must have at least 4 intubations on each demographic that you would work with. So neonates, pediatrics, adults, each quarter. And if you don't get that, they usually go down to the hospitals and try and get those, or you can do a sim lab. So communications and flight followings. You must have a post-accident incident policy. And you must be in communication, and CAMPS doesn't state what that should be, it just states that you should have one. But they do say that you should have communication with your dispatch center every 15 minutes when flying and 45 minutes when you're on the ground. Now, that does not mean that you have to call into them every 15 minutes. If they have flight following, that is just fine. But something we do need to look at. So let's say we're flying, and at 1500, you call into dispatch and say, hey, we're good. At 15:15, you miss that call. You never called in. They have 15 more minutes, dispatch will wait, to contact you, so they call you. And then they're going to wait another 15 minutes before they activate the post-accident incident policy. So you could be 45 minutes crashed before we activate this post-accident incident policy. So you call, no call, they call, all call. So every 15 minutes. So sterile cockpit, no communications unless it's about safety. During all critical phases of flight, so this, unless you're straight level cruising, it should be sterile cockpit. As far as protective clothing goes, it needs to be fire retardant, a 1/4 inch space between the uniform and your skin. You should have hearing protection and helmets. During night landings, the main thing that you have to have is communication with your ground personnel. And your optimal LZs, 75 by 75 day and 100 by 100 at night. Minimum equipment, 3 restraints for your stretcher, 3 IV pumps. This is just saying that you should be able to do 3 different medications at one time. So if that's 1 pump with 3 different ports, or 3 pumps with individual ports, whichever one. 2 sources of oxygen and suction, and you must be able to defibrillate in flight. The big thing is that you must be able to reach all of this while you're in flight, sitting down in your seat. You must be able to reach everything. So when we're talking about accepting a flight, there are 2 different areas that we're talking about, local and cross-country. Local is what your specific program has set up as their local flight patterns. So if it's within that area, you are local. Anything outside of that area is considered cross-country. So during the day, you must have a 500-foot ceiling and you must be able to see for 1 mile. For cross-country, it's a 1,000-foot ceiling and you must be able to see for 1 mile. Now at night, this is without night vision goggles. Local, ceiling has to be 800 and you must be able to see for 2 miles. And night, for cross-country, a 1,000-foot ceiling and you must be able to see for 3 miles. The number one cause of crash is pushing weather. The number one cause of crash is pushing the weather. I'm going to say it one more time. The number one cause of crash is pushing the weather. All right, so let's say we do crash. The ELT, the Emergency Location Transmitter, this will go off on a 121.5 hertz, and it is only activated if you actually crash at 4 Gs or more. If you don't hit 4 Gs when you crash, it can also be manually activated. So let's say now your pilot is incapacitated. So the first thing that we want to do is turn off the throttle, so don't be trying to go anywhere. Turn off the fuel, and then turn off the battery. Very well aware that these are not real, what it would look like inside the helicopter. So, all of that's done. The aircraft has stopped moving. We can now get out and go do our thing. The first thing we need to do, secure shelter. Then we'll get fire. Then we'll find water. And the very last thing we're going to worry about is getting food. All right, so when we talk about crashing, let's talk about our meeting location. So we crash. The first place we want to meet is at the 12 o'clock position, the front of the helicopter. Now, pay attention to this because this is different than what you're taught at Army level. So we want to go from the 12 o'clock position. If that is not a good area, we want to move over to the 3 o'clock position. Oh no, that is on fire too. All right, I'm going to move over to the 9 o'clock position. And that's not good either. Okay, finally, last but not least, this is probably your worst option, is the 6 o'clock position. We're just trying to avoid that tail rotor at all costs. All right, guys, that is it. So thanks for bearing with me, and I'll see y'all soon. Bye-bye.
My little Texas tornado blowing me away again. I swore it wouldn't happen again, but I looked at you and then I'm like a tumbleweed in a Wild West Texas wind.